again? Yeah, perfect. Okay. Well, I guess I'm out the gate. Lucky me, huh? I hope everyone's still awake. So my name is Jonathan Feist. I am a clinical pharmacist in a shared role with Lewis Drug and Sanford Health. I am embedded in Sanford as an ambulatory care pharmacist at 49th and Oxbow and 34th and Kiwanis. And so I'm going to just give you a little bit of an update here of what's kind of coming in the pipeline and why like these newer agents are maybe being explored, and kind of why are we just kind of at the tip of the iceberg right now of kind of what is to come. So just some disclosures. I do have some relevant financial relationships to disclose. I am a part of a speakers bureau for Novo Nordisk and Dexcom. So just some learning objectives. Upon completion, we'll hopefully be able to learn and understand the various treatment options for obesity. And we're going to explore new medication treatment options for these obesity, and summarize the recent indications for certain GLP-1 medications and examine the treatment pipeline. So current state, right now we have trizepatide, which is Zepbound, as most of you are aware. Other indications are obstructive sleep apnea. Right now there is an auto-injector, a vial, which is for cash pay, and just recently here this week, a quick pen that was announced for just cash pay options through Lilly Direct, and there is 4 doses in a pen with that. And then there is semaglutide, which is Wegovy. The other indications would be cardiovascular risk reduction and MASH. There is now a new oral pill that I will talk about later in this presentation, and an auto-injector. And then imicree and liraglutide with Saxenda, naltrexone and bupropion, which is Contrave, phentermine and topiramate, Casimia, and orlistat, or Xenacol. So Wegovy pill. Right now, essentially this is Rybelsus, which was in the diabetes space and was reformulated with their SNAC technology to have where there's less of the medication that is needed to help be absorbed in the GI tract. So the current doses with that are 1.5 milligram, 4 milligram, 9 milligram, and 25 milligram, which is a therapeutic dose. Still, the uniqueness of taking it just like within Rybelsus, administer in the morning on an empty stomach with up to 4 ounces of plain water, and also 30 minutes before eating food or other beverages, and taking other medication as well. And do not split and crush just because of how sensitive that molecule is. Indications for it, as well as with obesity, to reduce and maintain weight, excess weight in patients with either a BMI greater than or equal to 27 with one comorbidity, or greater than 30 with a BMI. And also they were able to have the cardiovascular risk reduction indication to reducing fatal MI, stroke. And so what this entails then for patients, especially in the Medicare space, with them not covering obesity as a primary diagnosis, is that allows also for coverage within Medicare. And so now you have the injection and also now the pill as with coverage within Medicare space. For patients who do not have coverage of Wegovy pill, they will pay $149 for the 1.5 milligram dose, and until April 15th, they'll be able to pay $149 for that 4 milligram dose. So for patients, under $200 option for a lot of patients. So what I'm seeing in the clinic side here, especially when that was announced, a lot more patients now are more eager to jump into the pool for cash pay. And so you're seeing that. After April, it will go to $200, that dose. And then the 9 milligram and 25 milligram are $300 a month with that. I think the nice thing is too, like for those that are using cash pay, you'll have that ability to kind of play with it. So some patients may just want to stay at that 4 milligram dose, which maybe isn't like what is therapeutic of the 25. I think the big thing to worry about with that 25 is going to be insurance coverages. So if patient is getting it covered for like especially obesity. They are going to want to, insurance plans are going to want to make you get that 25. So if a patient can't tolerate that 25 or can't or doesn't want to go up that high, you're not going to see continued coverage later on. So what's next? As you can see here, these are what is all kind of in different phase 1 through phase 4 trials. And so this, like, some of these are also exploring other indications such as MASH, cardiovascular risk reduction, OSA, chronic kidney disease. And roughly there's about 150 different molecules that are kind of being explored right now. So as you can see, we're not just stopping at trizepatide and semaglutide. And I think my nurses in the family med space, when I was talking to them here this week, I think I gave them a little bit of anxiety because every patient's calling in wanting this, and now they're like, now I got to remember more than 2. I have a hard enough time remembering 2. Now you're going to tell me there's more maybe coming on the horizon. And so just brace yourself. It's going to be fun. Okay. So why are we exploring other pathways besides GLP-1? And so this is potentially to get greater efficacy. So additional weight loss, targeting these multiple metabolic pathways as well, and then hopefully improve outcomes for weight loss and related comorbidities. So that's why you're seeing some of these other indications coming out, and why a lot of these molecules that are in market are trying to get to that other indications besides chronic weight management. It's kind of big. I guess it'll work. So as I have here, so there's these different pathways, and we'll go more in depth here, these enteropancreatic hormones. So there's glucagon, which is in the alpha cells, and then the amylin, which is in the beta cells in the pancreas. And you got PYY, which is in the ileum or L cells. GLP-1, as we're all familiar with, in the L cells. And then GIP, which is in the duodenum. Okay. So currently, these are GLP-1 agonists that are either FDA approved or in production in clinical trials. So not just semaglutide, and so there's orforglipron that we're going to talk about later. And then, yeah, so we'll go in here. So GLP-1 will decrease your appetite in the brain, works in the brain by decreasing that appetite, food intake, but then also can cause increased nausea. So that's why a lot of times when we're talking to patients, we're saying eating those small frequent meals, as I tell my patients too, I go, if you go to Pizza Ranch and you go to town on it, you're going to probably not feel good. So eating those small frequent meals, you're hopefully going to be able to tolerate the med as well. And it's just tied to the class in general. Also then too, in the pancreas, it's increasing that insulin. And what I like to tell patients too, it kind of supercharges the insulin that your body's already making, or if you are on insulin giving. So helps it hopefully decrease that insulin burden on patients who are even on insulin today. And then decreases glucagon, also will decrease gastric emptying and increase lipolysis, increase cardio protection, and increase heart rate. So these enteropancreatic hormones, that GIP, amylin, glucagon, and PYY. And so we'll explore these here now going forward. So GIP is with the K cells in the jejunum in response to food intake. Its physiological role will stimulate that insulin secretion, increase glucagon secretion, increase lipogenesis, and enhancement in lipid buffering capacity. In type 2 diabetes, it stimulates that insulin secretion and also eliminate glycemia is impaired. This is just more for completeness. A lot of these slides too are just more completeness too for you. That way you guys have a reference when some of these new medications come to market, and hopefully kind of simplify the different pathways. So like I just reiterated there's just a little bit of a diagram. And now we're going to talk about amylin. So amylin's co-secreted in the insulin by the beta cells of the pancreas, plays a key role in that postprandial satiety. So acts on the amylin receptors in the brainstem. So hopefully to reduce that food intake, improve glucose metabolism, delaying gastric emptying, and inhibiting glucagon secretion. It's not accompanied by expected contaminant decrease in energy expenditure, so that's sympathetic nervous system. Okay. Glucagon. So it's secreted by the pancreas alpha cells like we talked about, and its physiological site of action is in the liver. It'll increase that hepatic glucose production, and then the agonism effect reduces food intake and increases energy expenditure. So for completeness there, okay, PYY. I think that the only thing that's kind of cool about it is really more to just say it more than anything. But so co-secrete in the intestinal L cells together with GLP-1 following food intake. After secretion, it's rapidly cleaved to DPP-4. So for those of you who deal with a lot more diabetics, that's starting to get familiar, like, ooh, DPP-4, I've heard that before. So, hey, so that's where, okay, it's gonna work kind of that similar pathway. And the PYY3-36X on neuropeptide Y receptor, Y2R. This Y2R is present in the brain to cause an agonism effect to hopefully reduce that food intake and increase satiety. Okay, combo agents. So now we're going to see GLP-1 being added with all these other different kind of intrapancreatic hormones. So as you know, like trizepatide is GLP-1 with GIP. Then you're going to get GLP-1 and GIP antagonism, GLP-1 and glucagon coagonists, and then with amylin, and then triple G, so GLP-1, GIP, and glucagon, and then GLP-1 and PYY, and GLP-1 and GLP-2. And some of you are probably like, now there's a GLP-2? Like, where's this coming from? Okay, so these are some agents here. So as we know, like I mentioned, trizepatide is already FDA approved, but there are some other ones now, and it has turned into a rat race with all the pharmaceutical companies that are out there. So currently, right now, in the GLP-1 space, you have Novo Nordisk and Eli Lilly. And so, but now you're starting to see Roche get involved, BI is starting to get involved, even just some small, like Pfizer just spent $10 billion just to get a molecule to hopefully make it to market. So it's a rat race to get to the end and hopefully get a piece of the pie. But a lot of the price structure is changing as well as by every day, it seems like. So the GLP-1 GIP antagonism. So we don't really know for sure how this mechanism works. So that GIP receptor blockade, we're hoping, like they're thinking it has similar effects on reduction of food intake as that GIP receptor activation is going on. So materitide, Amgen is with this one, I'm pretty sure. And then in the phase 2 study showed that a mean weight loss of 17% of type 2 diabetes was in type 2 diabetics, and also 20% of mean weight loss in patients without type 2 diabetes. The weight loss trajectory, though, hadn't plateaued at that 52-week time point where they first started. So a lot of these trials here that I'm going to talk about are either in phase 2 or phase 1, a couple in phase 3. So I think a lot of these meds that are trying in the clinical trials are trying to hit above that 20% threshold. So just kind of keep that in mind. GLP-1 and glucagon co-agonists, and so as dutotide, that was in phase 3 using a 6 milligram weekly, showed 12.6% weight loss versus a 0.5% weight gain in that placebo arm. So that ain't near the 20% mark. So hopefully they're kind of coming up maybe with some other pathways, and so or some indications there. And so cevuridine is also one of those. Pramivudine is another one. So I just wanted to, a lot of these ones, it's just more for completeness sake. That way, hopefully, when there's more data involved, you guys will kind of say, oh, hey, I remember at least seeing this. Okay, GLP-1 and amylin, so CagriSema, and then Amycretin. And so there's also an oral agent that was phase 1, 16-week trial. That showed 13% weight loss. And then in the subcutaneous injection, the phase 2 36-week trial, so this Amycretin, is also kind of blended with a GLP-1, and so it's into one molecule with this amylin analog, and that showed 24.3%. And then we will talk about CagriSema at the end of this presentation a little bit more in depth. Triple G, so GLP-1, GIP, and glucagon. So retaglutide and 1 milligram, 4 milligram, 8 milligram, and 12 milligram in a phase 2 multi-arm design trial. In a 48-week study, the mean body weight loss with that 1 milligram was 8%. With the 4 milligram, 17.1, 8 milligram was 22.8, and the 12 was 24.2. And then there's also one more that is the UBT 251. That's in phase 1 trials right now. So more maybe down in the pipeline. But as you maybe have heard in TikTok or social media, you've heard triple G. And so a lot of people are very eager to see what the phase 3 trials will come about and what that weight loss looks like in patients down the road and what that looks like long-term for them. So as you can see, the mean body weight loss of 24.2%, that is very significant. And so for a lot of patients, that's just the mean. So that means some even lost more and maybe some even lost a little bit less than that. But if we're kind of sitting at that average of 24.2%, you think of patients with that and how much that almost at a quarter of their body weight can be lost with this med at least 48 weeks. That is pretty significant. GLP-1 and PYY. So this NNC 0165-1875, just very initial phase 1 trials going on, but just more for completeness sake for all of you. And then the GLP-1, GLP-2 co-agonists, so glutide. So the GLP-2 mechanism is secreted by the intestinal endocrine cells in response to nutrients. This hopefully will improve the intestinal barrier function, delay gastric motility, and improve tolerance to those GLP-1 agonists. So hopefully they're able to not have some of those side effects of that nausea, vomiting, diarrhea as well. Just a simple PYY analog is being studied too. So CIN 110, it's resulting in satiety and reduced energy consumption as well as what that mechanism is there. And so that's kind of in phase 1 and phase 2 trials as well. Then we're also expanding into other pathways too that may help with this weight loss development. And that's the myostatin activin receptor antagonists and control metabolic accelerators. MC4A is another one, and then the non-absorbed gastrointestinal agents, central acting agents, and cytokines. So this myostatin activating receptor antagonist, so this is stimulating the receptors in the myostatin the myostatin and activity inhibits skeletal muscle growth. So this is hopefully to reduce that muscle catabolism and a strategy hopefully to mitigate the weight loss or the loss of muscle mass that comes with weight loss through lifestyle, pharmacologic, or surgical therapy. So this is a monoclonal antibody infusion that is every 4 weeks. So it'll be interesting to see how this kind of plays in down the road if this class gets FDA approval. Because now if they're on a GLP-1 and they're losing muscle mass, or if they're on these other products and they're losing muscle mass, and we put them now on an infusion. So now we're adding even more costs, and they got to go in every month to go to the infusion center and sit there, and how long this infusion is still to be determined. And so a lot of variables to play down the road, and now you're going to increase cost as well with a lot of this. So it'll be interesting to see how this all kind of plays out. And then with the amylin agonists, so ZPB8396, AZD6234, and glutamine are kind of being studied as well. Phase 2 and phase 3 kind of going on as well. And then with these metabolic accelerators, and so these are promoting the mitochondrial uncoupling at the level of electron transport chain, increasing energy expenditure and increasing that basal metabolic rate. So the agent that's being studied is the HU6 oral agent. So being studied for type 2 diabetes, MASH, severe hypertriglyceridemia, heart failure with preserved ejection fraction. So as you're seeing, trying to get those more indications, hopefully to help benefit patients just who don't have obesity, but also have other chronic disease state, and a lot of times kind of go hand in hand as well. The melanocortin-4 receptor agonist. So this pathway is in the hypothalamus, and it's in a primitive neuronal system. It integrates peripheral signals into satiety, reduces that energy consumption, and increases energy expenditure. And so semaglutide is being studied for acquired hypothalamic obesity. And a lot of times you're going to see this more with patients who kind of have this genetic kind of disorder, especially in that hypothalamus obesity as well. So non-absorbed gastrointestinal lesions, so GLY 200, increases that mucus barrier in the duodenum, and it also leads to that exclusion in the foregut. It also kind of reproduces and mimics the metabolic effects of bariatric surgery. So it'll be interesting to see kind of how this one works, because if it's similar to what bariatric surgery is, and if patients can maintain that, it'll be kind of interesting if that weight loss expectancy is able to be maintained with that as well. So then you also see orlistat. So we mentioned that earlier. So, and then Acrobos, so an old school medication as well. And so why they're doing these together. So it's blocking that dietary fat absorption. So I think if you were here last year, I talked about fatty stools with orlistat and why anyone would want that. I don't know why, but there you go. And then and glucodase and amylase inhibitor delays that carb digestion in the GI tract. The essentially acting agents, they're going to be blocking the CB1 receptors located out the CNS. Also mitigate that metabolic dysfunction without affecting the brain. So also reducing the potential neuropsychiatric side effects. So this kind of class had really seen a lot of side effects affecting mood in patients. So that's why this is kind of so beneficial, where it's not kind of having those side effects of mood changes. So that's was a nice kind of segment into the later on of these clinical trials that are being progressed. And then you have Tesamet, which is testosterone and metoprolol, and you're like, why are we adding a beta blocker now with weight loss? What does this have to do with this? And so why that is being added is to hopefully, it's to kind of help with the increased cardiac safety that is being caused by the testosterone. So essentially you're taking another med to hopefully mitigate the side effects or causes of another med, which kind of goes against what we normally are told. Like, why are we going to prescribe a med to not prevent the side effect of another med? But they're hopefully they're seeing maybe some weight loss benefits. So testosterone is an inhibitor of the norepinephrine, dopamine, and serotonin, resulting in weight reduction. So we'll see how this one all pans out as well. Cytokines, so GDF15 is in multiple cells, including the cardiomyocytes, adipocytes, and macrophages. As you know, the theme here increases satiety, reduces food intake, and through actions in the central nervous system. And they're thinking that elevated GDF15 is correlated with weight loss. And then another molecule is that CIN 109. Okay. Now this is the good stuff. Sorry, I kind of bored you all to death with all that, so I apologize. But I thought, completeness sake, there you go. Try reading these articles that were all coming. I'm like, this is going to be fun to talk about. So I apologize with that. But here's kind of what I think everyone's excited about down the road here with what's maybe coming in 2026, or maybe here in early 2027. So orpeglagron is an oral agent that we'll talk about, Wegovy 7.2, CagriSema, and then retaglutide, like we mentioned earlier, with that 24% mean body weight loss. There is maybe potentially in late 2026 or early 2027 release dates. So as you can see now, we're going to have some different formulations and some different dosing as well. So this orpeglagron is an oral agent once daily. So 12 milligram, 24, 36, and 45. So in their phase 2 study, the phase 3 has not been fully released yet. So the BMI of greater than 27 without type 2 diabetes at 36 weeks there. The mean body change was 9.4 to 14.7 across the 4 doses versus 2.3% with placebo. So to kind of put that in comparison, Wegovy pill was at about 14%. So very similar there as well with patients. But the one nice thing about this, Med, is the pharmacokinetics aren't significantly affected by food consumption. So that is like where patients don't have to wait that 30 minutes before any other food, other tablets, no more than 4 ounces of water. So don't have to worry about that uniqueness of trying to take it. So the prandial restrictions may not be necessary for this oral medication, which is, I think, for some patients who have needle phobia, might be a great option for them and to continue on their weight loss journey. So CagriSema, so in a 68-week phase 3 trial comparing CagriSema to cardioglutide to 2.4 to semaglutide 2.4 and placebo. So the trials with CagriSema are called the REDEFINE trials. And so that was REDEFINE 1. REDEFINE 2 is also being studied in type 2 diabetes. The mean weight loss, so this is if, so like in the parentheses, I have here like analysis if the medications were taken as intended during that. So 20.4% with CagriSema with their initial, and then that if they were taken as intended, 22.7%. So pretty significant of what we have here on the market right now. And then cardioglutide was just 11.5% versus 11.8. 14.9 with semaglutide 2.4, 16.1 if intended, and then 3% with placebo, and then 2.3 if it was taken as intended as well. So this was announced on Monday, so I'm glad I kind of waited to give you all the most up-to-date info. So recently in the REDEFINE 4 trial, just in the preliminary reading, the primary endpoint with CagriSema, they were trying to demonstrate non-inferiority on weight loss for CagriSema to trizepatide, which is Zepbound after 84 weeks. So the CagriSema 2.4 had a 23% weight loss, mean weight loss in the treatment regimen estimate. So that means taking the medication as intended was 20.2%, where trizepatide 15 had 25% mean weight loss, and in their taken as intended was 23.6. And so CagriSema did not meet the primary endpoint of showing non-inferiority. So that was some interesting info that was kind of studied here. And then it sounds like here there's also going to be other trials going on with CagriSema at higher doses. And so you'll probably see here, as I'm going to mention here, about semaglutide 7.2. So maybe seeing that CagriSema 7.2 and 2.4 formulation. So as I mentioned here, Wegovy 7.2. So that step-up trial. And so with the phase 3B trial, it was 72 weeks. They compared semaglutide to 2.4 of semaglutide and placebo. And that mean weight body change at 72 weeks was 18.7% in the 7.2 arm versus 15.6 in the 2.4 and 3.9 in the placebo arm. So getting about 19% body weight reduction, which is nice, especially I think for patients who are already on semaglutide and they need it for that cardiovascular benefit. And now we'll have an option to kind of help and they plateaued, like a lot of times what happens in our weight loss journey with these anti-obesity medicines if we aren't doing lifestyle changes in conjunction with these. So having another option to hopefully step up in therapy will give patients other treatment options to stay on the molecule that they maybe are tolerating without having to change to maybe a different agent. So also here too, I think this is kind of nice to see where the percentage of patients that lost 10% versus 15 versus 20 versus 25 among that. So with the 10%, about 82% with the 7.2 lost 10% or more, 2.4 was 75, and 20% with placebo arm. And then as we keep getting more, the placebo arm definitely decreases. And even you start seeing some separation between 7.2 and the 2.4. I think it's kind of interesting. It is good to see, I think, for patients too, is in the 20% and the 25%, you're getting almost close to, you're getting 48% with 20% of, like lost 20% or more in that 7.2 milligram dose, and even 32% with that 7.2 lost 25% or more. So I think that is very significant and really can help patients and kind of really give them some hope to some major lifestyle change or major changes in their life, and hopefully get them, when I talk to patients too, I think one of the most important stories I've heard from a patient is where she was able to tell me, and she was in tears, and she goes, I'm able to shop in a different part of the store. You know, I can wear clothes that fit me better, and I feel like I just feel more confident. And I think that's why we're all kind of in healthcare, is to see those journeys. And so for patients to kind of know, like, there's maybe like where they're at right now is just maybe a start, and maybe where they're going to end like is maybe can be very significant and life-changing for them. And so I think that's the exciting thing down the road. Okay, there's references. Sorry, that was a little bit lengthy, but I apologize on that. Does anyone have any questions? Yes.
I just have a couple. I know it's cool that there's some research going into how to mass. In general, with the weight loss seen, is there a difference in lean body mass loss versus fat mass loss compared to like more standard calorie restriction that they noticed?
See, and they really hadn't kind of gone too in depth. I think that's going to be more in like those phase kind of 2 and 3 trials, like where they're going to try to separate that difference. That way we kind of have more definitive answers. I think that's kind of what they're trying to explore. Like, and it's going to be interesting how it does pan out.
And then as far as like the demographics of the group studied, is it like 18 and up count as adults?
Yep.
And then like, was there differences distinguish out versus like peri versus postmenopausal, or like an upper limit on ages or anything like that?
Yeah, on a lot of the trials, just in general, like it's going to be 18 and up. And so I think they haven't really broken down like perimenopausal or postmenopausal, like like for like with all of them. But I think that's something to consider because it does change, especially. Yes. Yep. In a lot of the trials too, the majority of participants were women compared to men. And so, like, especially in the semaglutide and retaglutide are more interest. And I think men are, hate to say it, are sometimes a lot more babies when it comes to needles. So they don't want to inject it, or their wife is hounding them to maybe lose some weight. I think they feel like they're fine. So I feel like, and I think that kind of relates to practice too of what we see, is the ones who are inquiring about this are probably more female, but we're starting to see a lot more men as well inquire about it. So yeah, good question.
Sorry, this might get to you guys. Did those studies that you are aware of include like guidelines for supplementation or anything like that throughout the studies, or was it kind of just?
It was just yeah. Okay. Yeah, and so I think that's kind of where that open label, like especially in that non-inferiority trial, that was open label, so it's kind of free reign, and so like that there wasn't like, oh, you can't take this or you can't.
Track that, like who took multivitamins or protein.
And so like in the initial readout, like they haven't announced that yet, so like that will be probably coming as well. Yeah, good questions, tough questions. So no, that's good.
With any other questions, if you raise your hand, I'll bring you the microphone so those online can hear us too.
Hey, so like with the indication of cardiovascular risk reduction too, in these trials, are they putting out results that like when someone took this combination drug or this drug that it reduced their risk by what % besides like their weight loss results?
Yeah, so in those, especially in the like Wegovy, stuff, like there's a number needed to treat, and so they're gonna, like a lot of these ones with these indications, they're gonna have like absolute risk reduction, number needed to treat, and so you're gonna see those there. And with the, like especially with Ozempic and that number needed to treat with a cardiovascular risk reduction, that was like 40, like it was below 50, I think like 44, 48. So like number, like over a 3-year time frame, so like to prevent one cardiovascular event. And so you're going to see too, like peripheral artery disease is also a lot of times what plans will allow for too. Sometimes you can sneak in some other ones besides previous heart attack or stroke, like with insurance plans, like depending on how loose they are. A lot of them, it's not really risk reduction, it's further risk reduction. So the plans are making them already have a heart attack or previous heart attack or stroke. So it's not like we're trying to prevent the first initial one, which seems kind of goofy. Like we want to hope, but then now we're trying to prevent multiple down the road with that. And so insurance plans a lot of times are handcuffing us in that type of aspect. But yeah, you'll start seeing like a lot of these ones, they're going to report like the number needed to treat in these trials as they're examining these. And so in the MASH space with semaglutide, it's also important to know that it's not just fatty liver across the board. It is a subset of those that are F2 and F3. And so I think that is going to be it's going to be interesting as this whole process with MASH evolves, because just even as a health system, now you're talking about FIB4 and FibroScans, and how does that pathway look? You just can't look at, insurance plans aren't going to let you look at AST and ALT and be like, oh yeah, they have fatty liver. Now they're going to want us to really kind of find in where these patients were in, because that's what was studied in those trials. Does that kind of answer the question maybe?
I think so. So like when you're like, just to be super clear, I think I understand this, but when you say the number to treat, so like for Ozempic, it's somewhere in the 40s, you would have to prescribe like 40 some people Ozempic to prevent one cardiovascular event.
Yeah. So like if you treated like, yeah, let's just say you treated 50 people. And so over 3 years, that would hope like is going to prevent one. You'd need to treat at least 50 people over 3 years to prevent one cardiovascular event to reduce that risk.
That number down.
Yeah. And and like a lot of your trials too, like the number needed to treat, like when I talk to even kind of patients or even providers, like if you're kind of below that 50 and below over 3 years, that's pretty significant. Because think about like your day in, like, especially in the fam med space or even at the our weight loss clinic, an average provider is seeing at least maybe 24 patients in a day. So that's like if you have like that's literally almost 2 days of clinic you're preventing an event. So I think that's kind of pretty significant within that week, and just how many come through your door that maybe would meet that criteria. Yeah, no, good question. 2? Oh yeah, 2. Yeah.
I have an online question here. It says, have there been any studies on mitigating side effects for some of the standard GLP-1 medications in practice? Side effects continue to be a barrier for implementing these medications long-term for many people who would benefit from them.
I don't know if there's any like true like kind of studies that are being out there. I just don't know off the top of my head, but I know there's been a lot more guidance from different associations, whether it's AFP or even just like the Pharmacy Association and even probably the ABOM Association, where they're talking about using, whether it's Reglan or Ondansetron, and you may even escalate to amend, but I think that's probably a little bit more on the high end. I think I feel like a lot of times that education with patients in explaining how the drug mechanism works and how it's decreasing that gastric emptying and how the portion sizes can really help with that side effect profile. At least just from my experience, I feel like when patients are aware of it and are being counseled on it, they can really succeed long-term with that. Not saying everyone does great, just because the side effects do become a barrier as well for a lot of patients. I think that's why we're seeing other pathways being explored too.
Okay, another online question. Is the general thought that once a patient has reached a maintenance period, it is anticipated that the medication will continue throughout their life? Do you think that when a person finally reaches their weight loss goals, that insurance companies will now refuse to continue therapy because the person may no longer meet the criteria they once did?
I think that's all of our fears, is that because this is a chronic disease, so it's not going to go away. It's there for life. And I think that's going to be I think a lot of our fears, and we are seeing it in some aspects. It's maybe not even due to like the PA coverage criteria, it's coming down to cost now. So like we saw that in the Federal Blue Cross space where cost was what, $60 a month, and then it jumped up to $600 for a lot of patients. Well, that really dictated coverage for them. And so I think there's still some guidance, I think, or there needs to be some kind of long-term kind of what is like our therapeutic dose, maintenance dose. You're starting to hear some associations kind of talking about, or even just other providers kind of toying around just because of the long half-life of these GLP-1 or GIP medications, like lasting at least technically a month in the body. They're maybe stretching it out to doing it every other week or every 2 weeks just to even help reduce cost or maintain. There's no official guidance or no published studies on that. It's just more of us trying to work with our patients and keep them on the meds, especially if they're paying cash, and make it as affordable as possible because they're seeing the results without being bankrupt as well by the cost of meds.
Okay, another question here. Is the kidney benefit mainly from weight loss or some other pathway?
So the exact pathway is not fully understood. You can relate into the semaglutide with Ozempic that they showed that in a post hoc analysis. So this is all just post hoc. There wasn't any like official kind of clinical trial. It's just them looking post hoc back on it, showing that the percentage of weight loss did not affect or did not sway the kidney benefits. So what it meant was that even if a patient lost a significant amount of weight, it didn't correlate with better kidney protection. It was the same across the board, whether they lost no weight versus they lost 25% of weight. And so it's just tied to that molecule is what they're perceiving or that they are reporting. And so can't officially say because it wasn't like, it was just post hoc looking back. So there's no like clear say, but you can kind of correlate that just by their initial analysis.
Another one here. Are there specific tools you use to document the weight loss journey and impact of medications?
I think that's a good question. I've had like this, the one patient I mentioned who had talked about shopping in a different part of the store. Was her idea was to help her kind of be more, I guess, accountable. Was she would use an Excel sheet and she would kind of mark out every time she went with the doses, like the different changes, and she would document what side effects she maybe had with that dose. And then she was very techie and even would get like a panorama kind of like picture of herself just so that way she could see that drastic change over time. And she would kind of do it like once initially she got to therapeutic doses, she would then do monthly kind of check-ins for herself. I would kind of ask Dr. Schriever, Dr. Adim, or any of the other weight management team, are you guys using anything in particular for your patients for documenting that? I think it's coming down to patient more than anything, like for tools to show like what they've lost. Yeah. Yeah. Yep. And yeah. Is that like flow sheets or synopsis? Okay. Perfect. So for those of you online, Dr. Schriever will kind of maybe explain a little bit more of that in her talk this afternoon, kind of some of the stuff that she's doing, body composition, and how she's kind of tracking that within EPIC. Any other questions? Perfect. Thank you.